Thank you, Vlad, also for granting me some additional time, because I think it's up already. Anyways, very glad to be here. Thank you for inviting me. Thanks for organizing this interesting meeting. And it's a tough task, cardiovascular risk in NAFLD. I'll try to sum it up for you. So these are my disclosures. I'm going to start out by highlighting some of the epidemiological evidence that is existing with regards to the link of NAFLD to cardiovascular disease. If we look at this graph, which comes out of the WHO Global Health Report 2018, you see why, at a global level, patients are losing lifetime and dying. And reason number one is ischemic heart disease. So it's right up there. It's one of the most common causes of death, and that's something that also happens to patients with NAFLD. But if you look down the line, you'll see that cirrhosis of the liver and also liver cancer are emerging on this list. They're also among the top reasons of loss of lifetime. And what does that mean? Well, it means that we do see common diseases in being casual for increase of death. We've discussed this, and you've seen this maybe before. Yesterday, the prevalence of NAFLD is very high, and we're talking about a lot of patients affected, but it's a smaller subset that develops clinical relevant liver disease and go on to develop liver outcomes. And the question is, what about the rest of the patients that do not develop liver outcomes? Are they at risk of cardiovascular disease? And it's difficult to dissect this because NAFLD and NASH, or the liver by itself, does not exist in an isolated room, but it's a lot of comorbidities that come along in these patients. So it's metabolically burdened patients that exhibit hyperlipidemia, diabetes, and arterial hypertension, all of which predispose them to liver disease on one side and cardiovascular disease on the other side. So the question is it the hen or the egg that's there in the first place? And while we know that it has to be the hen that has to be there before the egg, in NAFLD and cardiovascular disease, I think it's not as straightforward. It can be, as I tried to highlight you in the first few slides, an overlap of two very frequent diseases, totally independent. The question is, and I'm trying to answer that in the next slide, is there an intrinsic association, or is there even a mechanistic connection saying that, for example, liver disease, hepatic inflammation drives part of the cardiovascular outcomes we're observing in our patients? And that question is not totally resolved, but I'll try to lead you through what I think about it. So if we dig down into the pathophysiology, what drives liver disease, what drives cardiovascular disease, there's a lot of overlap. In cardiovascular disease, you see endothelial dysfunction, you see altered lipid metabolism, and you see, importantly, altered insulin resistance, and all of these aspects can be altered by liver disease. So based on this, you'll observe it in the same patient. You'll observe risk factors for NAFLD and cardiovascular disease, and again, systemic inflammation being an important aspect in this. So let's ask a different question. If a patient has diabetes, which is a prominent risk factor for cardiovascular disease, does having NAFLD affect his cardiovascular outcomes? And I think the answer is yes. Diabetic patients with NAFLD, and this comes from a current review, has worse micro and macrovesicular manifestations of liver disease. You see more chronic kidney, you see non-proliferative retinopathy, and proliferative retinopathy with regards to the microvesicular, but you also do see more macrovesicular complications, coronary artery disease, cerebral vascular disease. So having NAFLD predisposes or makes your severity clinical phenotype worse. So I think this is one aspect of the epidemiological data we have. Having NAFLD in a patient with diabetes makes your cardiovascular risk higher, and this is also something that can be observed from this meta-analysis. It's a very busy slide, but I'm going to highlight you the top results right here in the bottom. If you have NAFLD, your overall cardiovascular mortality risk is higher, and the odds ratio that comes out all of these different studies is 1.64, and it's independently of other metabolic risk factors associated with cardiovascular disease. This is a very large meta-analysis, large number of events. The problem is a little bit, there's a high heterogeneity. So some studies go one way, the other studies go the other way. That's what happens, and that's why you need meta-analyses. But I think the message out of these large data sets is clear. Having NAFLD is an independent risk factor for cardiovascular disease in this epidemiological association, actually having more severe liver disease. So you can observe a dose-dependent effect. Having more severe liver disease predisposes you to a greater cardiovascular disease risk, and this is something reassuring. I do see an association of disease activity here. So to follow down that line, how could this be connected? And there's this data I'm showing you on this slide comes out of two studies, one that's a little bit older and one that's fairly recent, actually co-authored by our chair here. Patients with NAFLD do have worse vascular disease. So intima-media thickness was measured here in patients with NAFLD, and you do see that compared to healthy controls, there's a step up having simple steatosis, or NASH increases your media thickness, which is a surrogate of having a cardiovascular event in the future. And the Paris group looked in a very large data set and tried to predict atherosclerosis at different sites. In this study, they observed that the upper body sites, namely coronary or carotid atherosclerosis, was dependent and influenced by the presence of hepatic steatosis using the fatty liver index here, as other traditional risk factors that we know, age and high blood pressure. So having NAFLD does something to your vasculature that's predisposing you to cardiovascular disease. And I think that's an important finding. Now, this data comes out of a German primary care setting disease analyzer database. It's not published quite yet, so hot and press, hopefully soon. We've analyzed in patients that do have NAFLD versus no NAFLD, the incidence of A, coronary heart disease, and B, myocardial infarction. You can see that's a big matched cohort study, a lot of patients here in primary care in Germany, and you do see the gap between having NAFLD and not having NAFLD is highly significant. It's not a huge numeric difference, but over this observational time of 10 years, you do see the lines separate, and having NAFLD puts you at risk of developing both either coronary heart disease that was not known at the time of the diagnosis of NAFLD or myocardial infarction. And that was, again, matched in these studies for age, sex, for example, hypertension, diabetes, suggesting an independent association of liver disease in the incidence of cardiovascular disease. And when I look into my patients that underwent liver biopsy, this is a study we did here. All patients with histologically confirmed NASH, they have a very high cardiovascular event risk from the beginning. You can use the Framingham risk categories to try to predict cardiovascular events, and the Framingham risk score separates patients into a low or a high 10-year risk of developing cardiovascular disease, and the high category starts with 20% within 10 years. And if I look at my my patient cohort that underwent liver histology, a third of them are in the high-risk group. So per se, even if they didn't have, and that's per definition in the Framingham risk score, so they did not have a prior cardiovascular event, they have a high risk of developing one within the next 10 years. And in this cohort, the independent predictor of being at a high risk was advanced fibrosis, while we did not observe an association with having either NASH or a high NAS score, or advanced fibrosis and a high NAS score. So as been shown in other meta-analyses in our cohort, F2 and more seems to be one of the predictors to move your patient into the high risk category to experience a cardiovascular event. And last slide with regards to the epidemiological differences, and this is where it becomes a little more tedious. is what is the role of genetics potentially? And you heard some talks yesterday. There are very prominent genetic locations that predispose you to developing hepatic steatosis. One is PNPLA3. And you could say that, well, if it's the fat in the liver that predisposes you to develop a cardiovascular event or cardiovascular disease, it should be those patients that do have a lot of fat in the liver. For example, the PNLP3 variant that's shown here. However, that data doesn't read out as clearly as you would if you think it's all about the fat and the hepatic accumulation of fat. And there are two studies I included into this slide. One that observed, yes, a positive correlation, however, only in the subgroups of patients with type 2 diabetes. And there's an Asian population that studied PNPLA3 with regards to the risk of cardiovascular disease, and they didn't observe that association in patients that were PNPLA3 positive. So I think this shows us, yes, genetics do influence the risk of having non-alcoholic fatty liver disease, but it's not straightforward translated into cardiovascular disease. And the second gene I'd actually like to address, and that very prominently highlights the problem of studying genetics in predisposing you to fatty liver disease, is TM6SF2. I'm saying that because it alters hepatic lipid export. So if you're not able to export your lipids into the periphery, of course, you're going to get more lipids in the liver and you get some more severe liver disease. On the other hand, if you are able to do so, all these lipids end up in your vasculature, which again predisposes you to cardiovascular disease. So there's a certain connection between, of course, how much lipids come out of the liver and where do they go, and how bad is that for your liver or cardiovascular system. But it's not a straight story of saying if all the fat stays in the liver, you're going to get cardiovascular disease. So that was the easy part. Now the big question is there really a mechanistic connection? And that's not as easily answered. I showed you all the epidemiological data, and I think it's very reassuring that NAFLD is an independent predictor of cardiovascular disease. And now you might ask me, well, then show me the evidence that this really drives cardiovascular disease. As a hepatologist, I always think of the liver being in the center. It can affect a lot of organs, of course. Cardiovascular disease is what I have to be talking on today. But I have to tell you, it's not as easy. I have to look into the literature of mouse models to really dissect how can I alter the liver phenotype and then study the cardiovascular outcome. And in theory, there's a lot of aspects that can be studied. You heard that there is a state of low chronic systemic inflammation. You can call it metabolic inflammation. Immune cells are altered. You can argue that there's a certain procoagulant situation in patients with obesity or NAFLD, being more pro-thrombogenic, that predisposes you to cardiovascular events. And of course, then there is the metabolic aspects, lipid and insulin abnormalities. I like this study because it dissects the adipose tissue and the liver compartment and studies insulin resistance and asks the question, how much immune activation do we actually see in the liver? And one theory could be that immune cells that are activated in the liver go somewhere else and do something bad, for example, in the endothelium. And this study that comes out of the Torino group looked at patients, non-diabetic patients with NAFLD, and they studied the adipose tissue and saw adipose tissue insulin resistance, and they saw systemic activation of macrophages, an immune activator, an immune marker that can lead to this metabolic inflammatory phenotype I was highlighting earlier. And then they went on and looked into the liver, and they see that, yes, there's also an immune activation, these macrophages in the liver. So if you do liver biopsy, you can actually see a correlation and an activation, Adams 17 here, compared to these markers on liver histology. So I think what this study tells us that, yes, you do have immune activation in the hepatic compartment that correlates with extrahepatic tissues. We've done a study where we looked at an inflammatory cytokine, interleukin-1 receptor, and we've knocked that out in hepatocytes specifically, so it's an animal model, and we feed animal high-fat diet versus control diet, and you see that both genotypes having IL-1 receptor in your hepatocytes or not doesn't change the obesity phenotype, but something we observed if you delete one cytokine in hepatocytes is that the animals with a deleted cytokine receptor had better insulin sensitivity. So they had lower levels of fasted insulin, they had a better HOMA-ER, and if you do a glucose challenge test, which is kind of like an OGTT, it's actually done intraperitoneal in these mice, you do see that the animals without the IL-1 receptor, it's the light gray here, do have a better or a higher sensitivity with regards to their insulin sensitivity. So what does that tell me? I think it reinforces the thinking that if you do have something going on in your hepatocytes, for example, the alteration of an immune cytokine receptor, you do get systemic effects like, for example, in this case here, insulin sensitivity. So the liver does something to the rest of the body, and the way it communicates with the rest of the body can be very effectively through microvesicles and exosomes, and they are actively secreted from hepatocytes, and they contain, for example, vasoactive mediators that go to different body parts and might well influence the endothelium and be responsible for some of the connection and epidemiological evidence we see in the clinical trials. And I actually like this paper, which is shown here, the data on the right side, published in JHAP recently, and what they did is, this is ex vivo challenge hepatocytes with oleic acid, and something they see is that these challenged, so actually it's monocytes, and if they're stressed with saturated, monosaturated fatty acids, they release extracellular vesicles that promote the attachment to endothelial cells. And I think that is something that could be a driver for, again, endothelial dysfunction. This study only looks into the liver, but it might be worth to actually try to replicate that and study its effect on endothelial cells, for example, in the heart. So to sum up, dear colleagues, dear chairman, I'd like to say that cardiovascular disease and NAFLD requires a very personalized approach. If I think of my patients in clinics, I think it's obvious, showed on the epidemiological data I presented, that yes, you should actively modify and manage the cardiovascular risk profiles of your patient. They are in a high risk category. 30% of my patients that undergo liver biopsy are in the highest event category according to the Framingham risk score. I think something we see frequently is that statins, mainly related to the risk of DILI in terms of primary care setting, is discontinued, something that could be deleterious for these patients. So I think you should reinforce and check if this is not something they really need. And I'd like to finish up and say that yes, liver-directed therapies will be available, and their effect in terms of cardiovascular outcomes will be very exciting to study in the future. And with that, I think one last slide. Again, it's an overlapping pathophysiology, problematic because there are few mechanistic studies and few data that defines actually the hepatic role in this context. But yes, cardiovascular disease has to be managed actively in our patients with NAFLD. Thank you.